Do you know what medical condition gets searched online more than heart disease, more than diabetes, more than cancer? 90% of people who have it say nothing to their doctor for months, sometimes years. They sit with the pain, the itching, the bleeding, and the shame, and they say absolutely nothing. It is not a tumor. It is not a failing heart. It is hemorrhoids, the single most common health search query in the United States, and the single most under-discussed medical condition in the English-speaking world. You will talk to your best friend for an hour about a headache. You will post online about your back pain. But hemorrhoids? Total silence. Complete, stubborn, self-destructive silence. And here is the brutal clinical reality. Your silence is not protecting you. It is not saving you from embarrassment. It is just giving a progressive vascular disease more time to damage your body. Because hemorrhoids do not resolve on their own. They do not plateau. They advance. And by the time most patients finally walk into my office, the condition has been quietly worsening for years. The healthcare system is not going to volunteer this information to you. There is no financial incentive to give you a real explanation and a real solution at a 15-minute appointment. Subscribe to Dr. Waterling and hit like right now. We are building toward 1,000 subscribers, people who want actual answers, not managed symptoms. I am Sam Waterling, 15 years of clinical practice. I see patients every day. I know exactly what it costs a person, physically, financially, psychologically, when a treatable condition is mismanaged or ignored until it requires surgery. Today, I am giving you the complete picture. Not a surface level overview, not a pamphlet. A full clinical explanation of what hemorrhoids actually are, where they actually come from, what is driving them at the mechanical and biochemical level, what you must stop doing immediately, and exactly what you should start doing today to reverse the trajectory of this disease before it reaches the point where a surgeon is your only remaining option. Let's begin at the very foundation, the anatomy. Because if you do not understand what hemorrhoids actually are, everything else I tell you will make no sense. Forget everything you have heard about cold surfaces, drafts, sitting on stone benches in winter. That is pure folklore with zero clinical basis. Hemorrhoids are a vascular condition. Specifically, they are a pathological dilation of veins, an abnormal, progressive enlargement and weakening of the blood vessel walls in the venous plexuses of the rectum. The rectum is the final section of your large intestine, the last several inches of the digestive tract before the anal opening. Surrounding the rectal wall is a dense network of small veins called the hemorrhoidal venous plexus. When those veins dilate abnormally, fill with stagnant blood, and the vessel walls begin to break down, that is hemorrhoidal disease. Now, you have almost certainly seen this same process happening somewhere else on the human body and recognized it immediately. When the veins in the legs become engorged, twisted, visibly swollen beneath the skin, we call that varicose veins. Varicose veins of the legs and hemorrhoids are the same fundamental pathological process. The same mechanism, the same type of vascular failure. The only difference is the location of the affected veins. And this is not a trivial observation. It is one of the most clinically important facts about hemorrhoids, and I will come back to it repeatedly throughout this explanation. Here is the core hydraulic principle that governs this entire condition. Every clinician learns this early, and it never stops being useful. When you observe a vein that is significantly dilated at a particular anatomical location, there is invariably some form of physical obstruction somewhere above that point. That obstruction is preventing venous blood from flowing upward back toward the heart the way it is supposed to. Blood backs up. Pressure builds within the vessel. The vein wall, unable to withstand the sustained hydraulic stress, begins to stretch and weaken. Over time, the vessel loses its structural integrity entirely. It no longer holds its shape. It dilates progressively. This is not a local problem at the site of the dilated vein. It is a downstream consequence of an upstream obstruction. This principle is easy to visualize. Think about a garden hose. Pinch it anywhere along its length. Immediately downstream of your fingers, the hose bulges. The water has nowhere to go. The pressure rises at the point of restriction. Release your grip and the bulge disappears instantly because the flow normalizes. Your venous system obeys exactly the same laws of fluid dynamics. If we see engorged, dilated hemorrhoidal veins, we know with certainty that somewhere above those veins, somewhere in the pelvic cavity, there is a mechanical obstruction compressing the major venous trunks that should be carrying blood upward toward the heart. So what is creating that obstruction? What is the internal blockage that is driving the venous congestion in your pelvis? The answer, in the vast majority of cases, is your own intestine, specifically a descensus of the intestines, meaning a downward displacement of the bowel out of its correct anatomical position and into the pelvic cavity. In a properly conditioned body, the intestines are held in the upper and middle abdominal cavity by a combination of muscular support from the abdominal wall, ligamentous suspension, and intra-abdominal pressure. When the muscles of the anterior abdominal wall are weak from years of sedentary work, from chronic poor posture, from lack of core conditioning, the intestines gradually descend. Gravity does its work across months and years. The heavy, displaced bowel sinks into the pelvis and begins to compress the large venous trunks that run through that space: the inferior vena cava, the iliac veins, the pelvic venous plexuses. Every vessel distal to that compression, every vein below the point of obstruction, begins to engorge with blood that cannot drain properly upward. Now, here's the clinical detail I want you to pay close attention to because it is something I observe in my practice with striking consistency. Patients who present with hemorrhoids almost invariably have some degree of varicose veins in their legs as well. Not always severe, not always symptomatic, but present. And this is not a coincidence. It is direct anatomical confirmation of the same phenomenon: a system-wide venous congestion driven by the same pelvic mechanical obstruction. The intestine sitting on the pelvic veins is acting as a tourniquet on the entire lower half of the venous system. Everything below that blockage, the rectal veins, the leg veins, the perineal vessels, is operating under chronically elevated venous pressure. You are not dealing with isolated hemorrhoids. You are dealing with a global vascular problem in the lower body, and the hemorrhoids are simply the most visible and symptomatic manifestation of it. The tourniquet analogy is worth making concrete because it perfectly illustrates the mechanism. A tourniquet is a compression band applied around a limb to stop blood flow. It is used in trauma medicine to control life-threatening hemorrhage from a severed artery. If I apply a tight tourniquet to your upper arm and you look at the veins of your forearm, you will watch them swell and become prominently visible within seconds. The moment I release the tourniquet, those veins collapse back to their normal caliber. The venous engorgement disappears completely, not because anything changed about the veins themselves, but because the obstruction was removed and normal flow was restored. Your descended intestine is functioning as a permanent internal tourniquet. It is sitting on your pelvic veins around the clock every day, compressing them with its weight. The hemorrhoidal veins downstream are responding to that sustained compression exactly the way your forearm veins respond to a tourniquet. The logical therapeutic conclusion from this understanding is straightforward, almost elegant in its simplicity. To resolve the venous congestion driving hemorrhoid development, we must either remove the obstruction or lift the bowel back into its correct anatomical position. When the intestines return to their proper location in the abdominal cavity and stop compressing the pelvic vasculature, venous blood can drain upward freely. The hydraulic pressure in the hemorrhoidal plexus normalizes. The stimulus driving continued vein dilation is removed. The disease stops progressing. And in many cases, over months of consistent effort, the existing dilation begins to partially reverse as the vein walls gradually recover structural tone. This is achieved through specific, targeted exercises designed to lift the pelvic organs and restore the muscular support structure that should be holding the intestines in position. These are not generic abdominal exercises. They are movements designed around the specific anatomical mechanism I have just described, lifting internal organ position through engagement of the deep postural muscles, the diaphragm, the pelvic floor, and the anterior abdominal wall in coordinated sequence. Patients who perform these exercises consistently and correctly, daily, without exception, see a reliable halt in hemorrhoid progression. I have watched this outcome repeat in my practice across 15 years. The disease does not vanish overnight, but it stops getting worse. And for a condition with the trajectory hemorrhoids have, stopping the progression is a profound and meaningful clinical result. Now I want to take you to a second layer of this problem, one that receives almost no attention in standard medical consultations, and that I consider critically important for understanding why some people develop severe hemorrhoids while others with similar lifestyle factors do not. Directly adjacent to the rectum, lying immediately posterior to it, immediately behind it, is a large triangular bone at the base of the spine called the sacrum. You know the sacrum. It is the solid, hard, flat bone that you feel pressing against the floor when you lie on your back on a firm surface. That hard structure in the center of your lower back, that is your sacrum. The rectum lies directly in front of it, separated by a thin layer of fascial tissue. Now here is the anatomical and physiological detail that almost no physician outside of osteopathic medicine will ever explain to you. In a healthy individual, the sacrum is not a completely fixed, rigid, immobile structure. It has measurable rhythmic micromovements, small oscillations occurring at a frequency of approximately 10 to 12 cycles per minute, that are synchronous with subtle movements of the cranial bones of the skull. This phenomenon is part of what osteopathic physicians call the primary respiratory mechanism. To define that term precisely, the primary respiratory mechanism refers to the rhythmic pulsation of cerebrospinal fluid, the clear, nutrient-rich fluid that circulates around the brain and spinal cord, and the corresponding subtle mechanical movement it produces throughout the skeletal framework from skull to sacrum. This is a distinct and separate rhythm from your heartbeat and from your breathing. It has its own independent frequency, and it is measurable with trained palpation. This mechanism is not a marginal curiosity. Osteopathic research and clinical experience place it as a foundational parameter of neurological health, endocrine function, and circulatory efficiency. The endocrine system, the network of glands that produce hormones including cortisol, thyroid hormone, sex hormones, and insulin, depends on adequate cerebrospinal fluid circulation for its regulatory communication pathways. Disruption of the primary respiratory mechanism correlates clinically with a wide range of systemic health problems. But what specifically concerns us in the context of hemorrhoids is this. The sacrum, as a moving component of this global system, produces a gentle, continuous micro-pumping action on the venous plexuses of the rectum that lie directly in front of it. Every subtle posterior-anterior oscillation of the sacrum creates a mild mechanical pressure wave through the pelvic tissues, a natural, passive, rhythmic massage of the hemorrhoidal venous networks that assists venous drainage upward through the pelvis. When sacral mobility is blocked, through falls on the tailbone, through years of sustained compression from sitting, through old pelvic injuries, through fascial adhesions that have accumulated over time, this natural pump stops functioning. Venous stasis in the rectal plexus increases substantially. The threshold for hemorrhoid development drops. Under these conditions, even moderate venous pressure from intestinal displacement is sufficient to drive significant hemorrhoidal disease. I have seen this clinically many times. Patients with relatively mild postural problems develop severe hemorrhoids because the secondary drainage mechanism, sacral micromovement, is completely absent. The treatment implication is clear. Restoring free sacral mobility is a direct, evidence-based therapeutic target in hemorrhoidal disease. A skilled osteopathic physician can assess sacral mobility through palpation by placing trained hands on the sacrum and the cranium simultaneously and detecting the quality, symmetry, and amplitude of the primary respiratory rhythm. Restrictions in that rhythm indicate fascial tension or joint dysfunction somewhere in the chain from skull to pelvis. Manual techniques to release those restrictions, applied to the sacroiliac joints, to the thoracolumbar fascia, to the pelvic floor, and sometimes to the cranial sutures, restore the micropump action and dramatically improve venous drainage from the rectum. In my clinical experience, patients who received combined osteopathic work addressing the abdomen, the pelvis, and the cranium in an integrated protocol showed marked improvement in hemorrhoidal symptoms, reduced swelling, reduced bleeding, improved comfort, without any pharmaceutical intervention beyond nutritional supplementation. But you do not have to wait for a specialist to begin addressing sacral mobility. There are effective exercises you can perform at home starting today that specifically target the sacroiliac joint. the joint connecting the sacrum to the large iliac bones on either side of the pelvis, and the ligaments that support and restrict it. I'm going to walk you through these in precise detail because technique matters here. Done incorrectly, these movements miss the target entirely. Done correctly, they produce a progressive, cumulative improvement in sacral mobility that you will be able to feel within a few weeks. The first exercise is performed standing. Stand barefoot on a firm floor. Fix your feet firmly in place. They should not slide or rotate. Now rotate both legs inward simultaneously with deliberate muscular effort, as if you are trying to screw both feet into the floor like large bolts. Your feet do not actually move, but the rotational muscular tension transmits upward through your tibias, your femurs, into your hip joints, and into your pelvic bones. As your pelvic bones rotate inward with this force, the sacrum is subjected to a stretching torsional force at the sacroiliac joints. Simultaneously, use the muscles of your posterior pelvis and lower back to push the sacrum backward, as if you were trying to press the back of your pelvis into a wall directly behind you. Hold this combined tension for several seconds. Release. Repeat 5 to 10 times every day. What you are doing is mechanically stretching the sacroiliac ligaments, the dense, powerful connective tissue bands that hold the sacrum to the iliac bones. In most people who have spent years sitting at desks, these ligaments are chronically shortened and stiff. Progressive daily stretching restores their elasticity, improves the range of sacral motion, and reestablishes the conditions for normal sacral micro movement. For those who have never heard the word sacrum before and are uncertain where exactly it is, lie on your back on a hard floor. The bone you feel pressing against the floor in the center of your lower back, the large, flat, solid bone, that is your sacrum. On either side of it are your iliac bones, the large wing-shaped bones that form the sides and back of your pelvis. The sacroiliac joints are the connections between these structures, one on each side of the sacrum. They are the target of everything I'm about to describe. The second exercise is performed lying on your back on the floor. Extend one leg completely straight and allow it to relax. Bend the opposite knee and draw it toward your torso, but here is the critical technical point that determines whether this exercise works or not. Do not pull the knee straight toward your chest. That direction stretches the hip capsule and the gluteal muscles, which is fine, but not what we need here. Instead, pull the knee diagonally toward your opposite shoulder. That specific diagonal vector creates maximum mechanical tension across the sacroiliac ligaments on the side of the bent knee. You will feel a deep pull in the posterior pelvis, in the region of the sacroiliac joint, when you have the angle correct. Hold the stretch for 10 to 15 seconds. Release. Repeat on both sides. Note carefully which side feels tighter, more resistant, more restricted. That asymmetry is clinically meaningful. It indicates unequal sacral mechanics and unequal venous drainage from the two sides of the pelvic floor. The advanced version of this exercise uses the edge of your bed or a firm sofa. Lie so that your hips are at the very edge of the surface. Allow the straight leg to hang freely off the edge, pulled toward the floor by gravity. This gravitational traction on the straight leg anchors the corresponding side of the pelvis firmly, creating a stable counterforce as you perform the diagonal pull with the bent leg on the opposite side. The sacroiliac stretch is substantially more intense in this position. The straight leg hanging downward can be actively pulled further toward the floor by contracting the hip flexors and quadriceps, increasing the pelvic anchoring force and making the stretch even more effective. Perform the movement slowly and deliberately. Change sides. Again, focus more repetitions and more sustained holds on the tighter, more restricted side. Over days and weeks of consistent daily practice, you will notice the asymmetry decreasing as both sides of the sacroiliac complex become more balanced and mobile. Now let's move to the biochemistry, the internal molecular environment that determines whether your vein walls can withstand the mechanical stresses I have been describing, or whether they fail under that stress and produce hemorrhoidal disease. Every significant case of hemorrhoids reflects a systemic weakness of connective tissue. This is not a peripheral factor. It is central to understanding why some people develop severe, rapidly progressing hemorrhoidal disease, while others with similar mechanical risk factors remain asymptomatic for years. The vein wall is a connective tissue structure. Its ability to maintain its caliber, its tubular shape under internal hydraulic pressure, depends entirely on the structural integrity of the proteins that compose it. The two key structural proteins of the vein wall are collagen and elastin. Collagen, the most abundant protein in the human body, provides tensile strength. It is the rigid scaffolding that prevents the vein from stretching beyond its normal diameter. Elastin provides recoil, the ability to stretch under pressure and return to baseline when the pressure normalizes. When you see a hemorrhoidal node that is severely prolapsed, dark blue or purplish red, visibly engorged, that bleeds on contact, you are looking at a vein wall that has lost both its collagen scaffold and its elastic recoil. The vessel wall has been reduced to the structural equivalent of a worn-out rubber band that has been overstretched too many times. It cannot recover its shape. It cannot contain the blood within its normal caliber. It will continue to stretch and deteriorate unless you intervene at the biochemical level and give the body the raw materials it needs to rebuild that structural framework. The single most important micronutrient for connective tissue integrity is vitamin D. Vitamin D, technically a secosteroid hormone rather than a classical vitamin, because it is synthesized in the skin from sunlight exposure and acts on nuclear receptors throughout the body, directly regulates the gene expression pathways responsible for collagen synthesis, collagen cross-linking, and extracellular matrix maintenance. Collagen cross-linking refers to the formation of chemical bonds between adjacent collagen fibers that give the matrix its rigidity and resistance to deformation. Without adequate vitamin D, collagen synthesis is impaired. Cross-linking is incomplete. The resulting connective tissue is softer, more compliant, less able to resist deformation under mechanical stress. The vein wall stretches when it should hold. This is not a theoretical concern. Vitamin D deficiency is extraordinarily common in the general population, particularly in regions with limited sun exposure and in people who work indoors. Having your vitamin D level measured with a simple blood test is one of the most useful things you can do for your overall health. And correcting a deficiency is among the highest yield interventions available for vascular and connective tissue conditions. Beyond vitamin D, the complete connective tissue support protocol requires vitamin C, magnesium, zinc, selenium, iodine, and iron. Let me explain briefly why each of these matters. Vitamin C is the rate-limiting cofactor for the enzyme prolyl hydroxylase, the enzyme that performs a critical modification to newly synthesized collagen chains that is required before those chains can be assembled into functional collagen fibers. Without adequate vitamin C, collagen synthesis physically cannot proceed past a certain step. The result is defective collagen, fragile, poorly cross-linked, unable to provide the structural support the vein wall needs. This is why scurvy, the disease of severe vitamin C deficiency, produces bleeding, tissue fragility, and vascular failure. You do not need to develop scurvy for subclinical vitamin C deficiency to impair your connective tissue quality. Magnesium is required for over 300 enzymatic reactions in the body, many of which are involved in protein synthesis and cellular energy production, processes that underpin tissue repair and regeneration. Zinc is essential for the activity of matrix metalloproteinases, enzymes that regulate the controlled remodeling and turnover of extracellular matrix proteins, including collagen. Selenium and iodine support thyroid function, and thyroid hormone is a major regulator of connective tissue metabolism and vascular tone. Iron is required for the same collagen synthesis pathway as vitamin C. It serves as a cofactor for lysyl hydroxylase, another enzyme critical to collagen fiber maturation. All of these nutrients are available without prescription at any pharmacy. A complete 30-day supply of all of them combined will cost you somewhere between $20 and $50 at most. That is not a significant financial investment relative to the cost of what you are trying to prevent, which at the far end of the spectrum is hemorrhoidal surgery, with its recovery time, its complications, and its cost measured in hundreds or thousands of dollars. Correct the deficiencies. Give your body the chemistry it needs to rebuild the structures that are failing. This is not optional if you are serious about managing this condition without surgical intervention. Let's talk about what you must eliminate from your daily habits immediately if hemorrhoids are already present. Every behavior that elevates intra-abdominal pressure, the pressure inside the abdominal cavity, directly worsens the mechanical compression of the pelvic veins and accelerates hemorrhoid progression. This is not theoretical. The physics are direct and immediate. Heavy lifting is the most obvious offender. Whether you are lifting weights at a gym, moving furniture, carrying heavy bags, or loading boxes at work, every maximum effort lift causes a Valsalva maneuver. The Valsalva maneuver is the physiological response of closing the glottis, the opening at the top of the airway, and straining against a closed airway, which massively spikes intra-abdominal and intrathoracic pressure in the seconds of maximal exertion. Venous pressure in the pelvis surges correspondingly. If you already have compromised hemorrhoidal veins, that repeated pressure spike is doing cumulative damage every time you lift heavy. Heavy lifting must stop until the underlying condition is addressed. Chronic constipation is equally destructive and arguably more insidious because it happens every single day, often multiple times a day, often for years. The act of straining to pass hard stool generates exactly the same venous pressure surge as heavy lifting. You can measure this on yourself right now. Sit at your desk, hold your breath, and strain as if you were trying to pass stool against resistance. Look at the veins on the back of your hand or forearm. Watch them engorge visibly in real time. Those same pressure waves are hitting the rectal veins every time you strain on the toilet. For someone with hemorrhoidal disease, each straining episode is a small additional injury to already compromised vein walls. Multiply that by 365 days a year across years of chronic constipation, and you understand why untreated hemorrhoids progress steadily and reliably. Any sport or physical activity that carries risk of trauma to the pelvis or tailbone must be avoided without exception. Ice skating, snowboarding, inline skating, horseback riding, all of these carry a meaningful risk of hard falls directly onto the coccyx and sacrum. The coccyx is the small, final segment of the spine just below the sacrum. A single hard impact on the coccyx can cause immediate, significant sacral dysfunction, blocking sacral mobility completely. One fall can undo weeks or months of therapeutic progress in the sacral mobility work I described earlier. The risk is not worth it. These activities need to be suspended during the treatment period. There is an entire patient population that deserves specific, detailed clinical attention here. Women during and after pregnancy. The biomechanics of pregnancy create almost the ideal conditions for hemorrhoid development and severe progression. As the fetus grows across the second and third trimesters, the expanding uterus exerts direct, sustained, progressively increasing compression on the inferior vena cava and the iliac veins, the major venous trunks responsible for draining blood from the entire lower half of the body. This is the same mechanical obstruction mechanism we have been discussing, but now it is being generated not by descended intestines, but by a rapidly enlarging organ that is not going to stop growing for several months. Venous pressure in the hemorrhoidal plexus rises correspondingly throughout the pregnancy. In women whose connective tissue is already suboptimal because of nutritional deficiencies, because of previous pelvic trauma, because of poor core conditioning, this sustained pressure elevation is sufficient to produce significant hemorrhoidal disease that may persist and worsen after delivery. Labor itself introduces an additional acute mechanical insult. The bearing down efforts of the second stage of labor generate extremely high intra-abdominal pressure, comparable to or exceeding the pressures of maximal weightlifting sustained for prolonged periods during active pushing. For a woman with pre-existing hemorrhoidal vein weakness, this can cause acute hemorrhoidal prolapse and thrombosis, the sudden formation of a blood clot within a hemorrhoidal vein, which produces severe, immediate pain and significant swelling. The clinical recommendation I give every woman of reproductive age who comes to me with any sign of pelvic vascular issues is this: address these problems proactively before pregnancy, not reactively after the damage has been done. Restore pelvic organ position, correct all micronutrient deficiencies, build connective tissue resilience, go into pregnancy with strong, well-nourished, properly supported pelvic tissues. A woman who does this gives herself the best possible chance of navigating pregnancy and delivery without lasting vascular damage, and gives her child the benefit of a healthy, fully functional mother. Bowel regularity is a therapeutic intervention, not just a comfort consideration. I want to be precise about what I mean by regular and easy bowel movements in the context of hemorrhoidal disease. The goal is stool that passes without any straining, without any bearing down, without any prolonged sitting and effortful attempts. Formed, soft, bulky stool that slides through the anal canal with minimal resistance. Achieving this requires adequate hydration. Most people are chronically underhydrated, and this directly contributes to stool hardness. It requires adequate dietary fiber. Soluble fiber from vegetables, fruits, and legumes adds bulk and retains water in the stool. It requires avoiding foods that promote stool hardness and sluggish transit. Processed foods, refined flour, minimal water intake, and it requires attention to toilet posture, which is something almost no physician ever discusses with patients, and yet is one of the most mechanically important factors in straining-free defecation. The human rectum is not designed for a 90-degree seated position. The standard Western toilet places the hips and knees at approximately a right angle. This creates a natural kink in the anorectal canal called the anorectal angle, which is the bend between the anal canal and the rectum. This angle is a continence mechanism. It helps prevent involuntary leakage, but it also creates resistance to stool passage when you are trying to defecate. In a squatting position, the posture in which the human body actually evolved to defecate, the anorectal angle straightens completely. The canal becomes a straight tube. Stool passes with essentially no muscular effort, no straining, no pressure surge. You can approximate the squatting position on a standard toilet by placing a low footstool under your feet, raising your knees above the level of your hips. This simple, free, immediately available intervention can significantly reduce or eliminate straining at toilet. It costs nothing, it requires no prescription, and it removes one of the daily mechanical stressors that is actively worsening your hemorrhoidal disease every single time you use the bathroom. I want to address the prognosis directly because I think many patients come to their first appointment with either excessive optimism or excessive pessimism about where this condition is heading, and both extremes lead to poor decisions. Untreated hemorrhoidal disease follows a predictable natural history. Stage 1. Internal hemorrhoids that bleed during defecation but do not prolapse, do not protrude outside the anal canal. Stage 2. Hemorrhoids that prolapse during straining but reduce spontaneously, go back inside on their own. Stage 3. Hemorrhoids that prolapse and require manual reduction. You have to push them back in with your fingers. Stage 4. Permanently prolapsed hemorrhoids that cannot be reduced, are constantly exposed, constantly irritated, prone to mucus discharge, bleeding, and acute thrombotic episodes. Acute thrombosis, sudden clot formation inside a hemorrhoidal vein, produces severe, sudden onset pain that is genuinely debilitating. Patients in thrombotic crises often present to emergency departments. In advanced stages, chronic low-grade bleeding leads to iron deficiency anemia, a state in which your blood cannot carry adequate oxygen, producing fatigue, weakness, cognitive fog, and reduced exercise tolerance that many patients attribute to aging or stress rather than to their untreated hemorrhoidal disease. The people who reach stage 3 or stage 4, the people who require rubber band ligation, sclerotherapy, hemorrhoidopexy, or formal hemorrhoidectomy, are almost invariably people who spent years treating their hemorrhoids as a minor inconvenience, who applied topical creams and hoped the problem would stabilize. Creams reduce symptoms temporarily. They reduce local inflammation slightly. They do not address the mechanical cause. They do not rebuild the vein wall. They do not lift your intestines off your pelvic veins. They do not restore sacral mobility. They allow the underlying disease to advance unchecked behind a temporary mask of symptom relief. But here is the other side of that prognosis, which is equally important. Having hemorrhoids does not mean you are on an inevitable path to surgery. Exactly the same way that having varicose veins in your legs does not automatically mean you are going to a vascular surgeon next month. The natural history I just described is the natural history of untreated, unaddressed hemorrhoidal disease. It is not the natural history of a condition that is being actively and correctly managed. If you eliminate the mechanical obstruction by restoring pelvic organ position, if you restore sacral mobility and reestablish the natural venous microdrainage mechanism, if you rebuild connective tissue quality through comprehensive micronutrient correction, if you eliminate the daily pressure stressors of straining, heavy lifting, and pelvic trauma, then the disease can remain stable, non-progressive, and clinically manageable for years, without pain, without significant bleeding, without any surgical intervention. The condition does not disappear. The structural changes that have already occurred in the vein walls do not completely reverse. But the progression stops. The acute episodes stop. The daily discomfort stops. And that represents a fundamental, life-altering improvement in quality of life for someone who has been suffering with this condition for years. Here is something I pay close attention to clinically when I am assessing the urgency and approach for a hemorrhoid patient. And it is something I want to use to ask you a direct question. The risk profile for hemorrhoidal disease changes significantly with age. Below 35, most cases are driven primarily by lifestyle factors: sedentary work, poor diet, nutritional deficiencies, lack of physical conditioning. These cases respond well and relatively quickly to conservative management. After 45, the picture changes. Connective tissue quality begins a measurable physiological decline. Collagen synthesis slows. Sex hormone levels, both estrogen and testosterone, begin to fall, and both of these hormones play important roles in maintaining vascular wall integrity and connective tissue elasticity. The sacroiliac joints accumulate decades of compressive loading and progressive restriction. The cumulative effect is that the same mechanical stressors produce more rapid and more severe vascular damage in a 50-year-old than they would in a 30-year-old. Treatment timelines are longer, micronutrient correction becomes more critical, and the window before surgical intervention becomes necessary is narrower. So here's my question to you, and it is not rhetorical. It is clinically relevant to how I want to structure the content I make for this audience. How old are you? Drop your age in the comments below. I genuinely want to see what the age distribution of this channel's viewers looks like, so I can prioritize the content that is most relevant and most urgent for the people who actually need it. Here is your direct clinical action plan. These are not suggestions, these are physician's instructions. If you have any current sign of hemorrhoidal disease, any itching, discomfort, rectal bleeding, prolapse, or simply a confirmed diagnosis, begin today. First, start pelvic organ lifting exercises and perform them every single day without exception. Consistency over weeks and months is what produces results. Second, begin the sacral mobility exercises I described, the standing leg rotation exercise and the diagonal knee pull in lying. 5 to 10 repetitions on each side daily with deliberate extra focus on the tighter side. Third, start a comprehensive micronutrient protocol. Vitamin D at a dose appropriate to your documented deficiency level, vitamin C, magnesium, zinc, selenium, iodine, and iron. Have your levels tested if possible so you are correcting documented deficiencies rather than guessing. The entire supplement course will cost you $20 to $50 at a pharmacy. Fourth, eliminate heavy lifting immediately and keep it eliminated until you have made substantial progress with the mechanical treatment. Fifth, get your bowel habits into order. Hydration, fiber, footstool posture, zero straining tolerance. Every straining episode is a backward step. Sixth, avoid any activity with risk of pelvic trauma. Seventh, put the topical creams away. They are not treatment. Do all of this consistently, simultaneously, for a sustained period. We are talking months, not days, and you will see real clinical change. The disease will stop advancing. Your symptoms will reduce. Your risk of progressing to surgical grade disease will drop significantly. This is not a promise of a miracle cure. This is a rational, evidence-based, mechanistically coherent treatment protocol that addresses the actual drivers of hemorrhoidal disease rather than masking its symptoms. Your doctor is not going to walk you through this at a standard appointment. Not because they do not care, most of them do, but because a 15-minute appointment does not allow it, and because the healthcare system is economically structured around managing symptoms rather than eliminating root causes. There is no billing code for a 45-minute explanation of pelvic biomechanics and connective tissue physiology. There is a billing code for prescribing a topical cream and scheduling a follow-up. Subscribe to Dr. Waterling, hit like, and help this channel reach 1,000 subscribers. Real, complete, clinically honest medical information, freely available to everyone. That is what we are building here.